Hi, my name is Luciano Costa. I'm a multiple myeloma physician at the University of Alabama at Birmingham. And I'm here at the American Society of Clinical Oncology annual meeting to present in behalf of my colleagues and co-investigators the results of a phase 2 trial of the combination of carfilzomib, venetoclax, and dexamethasone in patients with relapsed and refractory multiple myeloma. So multiple myeloma cells, like most cancer cells, rely heavily on the expression of anti-apoptotic molecules to survive and to resist damage caused by other myeloma, in this case myeloma-directed therapies. In multiple myeloma, we know MCL1 is the most relevant anti-apoptotic molecule. It's part of the BCL2 family. But it also happens that proteasome inhibitors, which are nearly ubiquitously used to treat multiple myeloma nowadays, do inhibit MCL1 indirectly through the preventing the degradation of NOXA, which is a binder of MCL1 through the proteasome. On doing so, it makes BCL2 more relevant, and BCL2 upregulation turns out to be a mechanism of escape of therapy on proteasome inhibitors. Therefore, by using a small molecule inhibitor of BCL2, in this case venetoclax, in combination with a second generation proteasome inhibitor, carfilzomib, we have the chance to simultaneously antagonize two important anti-apoptotic molecules in multiple myeloma. So this study included patients who had 1 to 3 prior lines of therapy, and patients who were relapsed or refractory, the majority of patients being refractory to the last line of therapy. 2/3 of our patients were refractory to prior IMiDs, and 1/3 of the patients were refractory to prior proteasome inhibitor, actually half of the patients. And interesting, 1/3 of the patients were double refractory. And the study had an initial part 1 where we tested the safety of venetoclax in 400 milligrams and subsequently 800 milligrams with different dose and schedule of carfilzomib, the weekly schedule of lower dose, 27 milligrams per square meter, the higher dose, 56 milligrams per square meter, and the weekly 70 milligrams per square meter dose as previously shown in the Champion-1 study, and further explore on the ARROW study that also presented during this conference. That cohort of 70 milligrams in combination with venetoclax, 800 milligrams was the cohort that we choose to expand. There were no dose-limiting toxicity in any of the cohorts in part 1. Therefore, the study expanded in the part 2 with the 70 milligrams. We accrue 42 patients, of which the majority are still on therapy. Of those patients, we have efficacy data for 30 patients who had been accrued prior to 3 months prior to the data cutoff. Among the 42 patients who enrolled in the study, we saw the majority of patients had some adverse events, mostly being diarrhea and some cytopenias that for the most part were minor and did not require dose reduction. The most common grade 3 and 4 adverse events were cytopenias that were also asymptomatic. We saw the same or very similar rate of cardiovascular toxicity, particularly hypertension, as we have seen in prior carfilzomib studies. Of interest, we had a very high response rate that was 83%. We saw a similarly high response rate in patients who are IMiD refractory than we saw in patients who are bortezomib refractory and patients who are double refractory, although the numbers there tends to be quite small. There has been some great interest on seeing how the venetoclax performs among different cytogenetic subsets, knowing that this is a drug that is exquisitely active among patients with 11-14 translocation. Although all 7 patients with 11-14 translocation did respond, including 6 patients who had a very good partial remission or better, we saw a response rate higher than 70% even among the non-11-14 patients. Many therapies, most therapies, tend to perform less well on high-risk cytogenetic high-risk patients. But for this combination, we saw a response rate greater than 80%, even among high-risk patients, those being the 17p deletion, 414 translocation, and 1416 translocations. This trial continues. As time goes by, we expect to gain some more knowledge on the long-term safety and also how the duration of those remissions. And we believe this is going to turn out to be an attractive combination, particularly patients with refractory disease or relapsed disease after prior exposure to an IMiD and a proteasome inhibitor.